Thank you, Frank. Mr. Chairman, ladies and gentlemen. I do believe the debate is over. I do believe that EVAR is better for ruptured aortic aneurysms, even if the randomized controlled trials claim otherwise. I don't say that they say it, they claim it. I think that, sadly, this is no longer a medical issue. I don't think it has been a medical issue for some time. I think this is a logistical and political issue. I have no disclosures. The typical ruptured patient is a male, 70 to 80 years old, with multiple comorbidities. He is in immediate danger of life. He is bleeding, and there are two ways to stop that bleed. It's either open surgical repair or it's EVAR. Both are fully possible. The only obvious difference between the two techniques is that the EVAR is associated with less trauma. When it comes to the randomized controlled trials to assess which one is best, it is notoriously difficult to conduct such studies. I find that most colleagues today who master fully the endovascular skills will find it difficult to have equipoise in this matter, and if you don't have equipoise, it's actually unethical to conduct such a study. So that is one hurdle if you want to continue with studies, I believe. On top of that, there are all the practicalities with the urgent, dramatic scenario. I won't go through all of that, but it is very difficult to conduct a good study in a ruptured setting. Perhaps that is what has contributed to some of the difficulties when it comes to selecting the patients. And if you look at the exclusion criteria in the best of the trials, I believe, the British Improved trial, I can't go through all these details, but if you look at them, you will see that many of the patients who were excluded from EVAR would have perhaps benefited the most from having an endovascular repair. Also, the exclusion criteria show you that the availability of endovascular repair was poor at many of the centers, as was their experience of the endovascular technology. But that's not enough. Also, the inclusion criteria were perhaps suboptimal, because also the symptomatic AAAs were included. And there you don't anticipate a huge difference, and none of the trials were powered to show such difference. So you can really question the validity of the existing randomized controlled trials. But let's, for this debate now, accept the data as is. And you have all seen this table before, and what it's about is comparing the mortality between the groups. And the official data from, again, the best, the improved trial, is that the mortality after EVAR was 25%, while it was 50% higher after the open surgical repair, 37%. In that scenario, I can't understand why it's being claimed repeatedly and still today that there is no difference between the two techniques. I think the difference is huge. I can't understand that. But again, let's accept even that. Let's accept that there is perhaps no difference. Then again, we stand behind with the two different techniques, the open repair and the endo repair. And as I said before, the only difference we are confident about is that the EVAR is a lesser trauma to the patient. So if there is no difference and one is a lesser trauma, how can you justify the open repair? Where is that ethical decision? And why do multiple various organizations, colleagues, institutions keep advocating that open repair is not only justified, but perhaps should be carried out? Only last year did the NICE guidelines change in the UK. I won't go into detail there, but even that change is a little bit difficult to explain for me. So from my perspective, the randomized controlled trials, what they have achieved is to mistakenly justify the open surgical repair, to justify the continued use of open repair. And thereby, they have delayed the implementation of emergency EVAR by perhaps a decade. And I fear that potentially that has cost many lives. I don't think it is possible to have two hospitals nearby where one does 100% open repair and the other does 100% EVAR. That is not right. And I suppose that if media and people found out, we would have some nasty headlines hitting the press. And if it was your father on the table, I think we should probably have a new hashtag #MeToo movement, perhaps hashtag #MyAAA2 movement. So in conclusion, Mr. Chairman, ladies and gentlemen, when it comes to emergency EVAR, I think that the existing randomized controlled trials are poorly valid, but they do confirm a 50% higher mortality rate for open surgical repair. The results have been misinterpreted to justify open surgical repair. The delay, it has delayed the implementation of emergency EVAR, and this has potentially cost lives. I do believe that EVAR is a better solution for these patients. Thank you for your attention.